Hello friends. Now in this video today, I bring to you a very interesting topic, which is evaluation of acute pelvic pain in reproductive age group women. Now, why is it important? We all work in emergencies, and it is often that we encounter women in the casualty or emergency complaining with acute pelvic pain. Now, to know about what to evaluate, you need to know what could be the possible causes. Broadly, the possible causes could vary from being mildly symptomatic, not so serious causes, to maybe something which could be very severely symptomatic, a serious cause, maybe even a life-threatening surgical emergency. That's why it is very important to know what we're looking for, to know what causes we want to rule out, and therefore that will determine how should we be evaluating such patients. Okay, so let's get started and talk about what is the nature of an acute pelvic pain. So an acute pelvic pain is sudden in onset, right? It's usually sharp in intensity, and it is usually short-lived. It is also often associated with certain additional accompaniment of symptoms, like the woman could be complaining of nausea and vomiting. The woman could also be complaining of sweating, diaphoresis, like sudden onset of acute sweating episode, or maybe even apprehension. Now, these are what we call as autonomic reflex response. And this symptomatology is arising because of autonomic reflex responses. You see, the acute pelvic pain that is arising because of the visceral pain. It's arising from the viscera. And visceral pain is, transmitted by a way of parasympathetic and a sympathetic nervous system to the spinal cord and then to the central nervous system. So it is the reflex responses arising from these sympathetic and parasympathetic ganglia and pathways that is responsible for this set of symptoms. Other than this, there can also be symptomatology specific to the underlying process that is unfolding. It could be infection. It could be some blood collection inside the pelvis. So yes, we're going to talk about those additional symptomatology also. But yes, first of all, let us identify what are the causes that we are seeking. So this is the region of the pelvis which we're talking about, where the woman will complain of pain. And if you look at what all is located in the pelvis, you'll realize we have the gynae causes of pain arising from the genital tract. We can have non-gynae causes of pain, like we could have gastrointestinal causes of pain, and yes, particularly to that part of the gut which is in the pelvis. So you could have, intestinal obstruction or intestinal rupture, like it could be from the sigmoid colon, it could be from the rectum, it could be from the cecum, right? Or it could also be an appendicitis, or it could be a gastroenteritis, which could be responsible for the gastrointestinal causes. You could have urinary causes of acute pelvic pain, right? You could have urinary tract infection, you could have cystitis, you could have stones, right? So urolithiasis, the stones could be in the bladder, you could have bladder stones, you could have stones in the lower ureter, which could be responsible for pelvic pain, right? And apart from this, yes, less common, but should be kept in mind, there could be musculoskeletal causes of pain. Like, for instance, there could be an abdominal wall hematoma. So you should keep this possibility in mind. Inguinal hernias is a possibility. Yes, inguinal hernias are much less commonly seen in women as compared to male, but the possibility should be kept in mind. Now, focusing on my area, that's the gynecological causes of pain. So broadly, we can divide gynecological causes of pain into causes which occur as complications of pregnancy and causes which can happen outside of pregnancy, or they could be coincidental. Okay, they could be coincidental with pregnancy as well. Now, if you talk about complications of pregnancy, yes, You could have acute pelvic pain arising because of an abnormal extrauterine location of pregnancy, which we call as ectopic pregnancy. That ectopic pregnancy is most commonly in the fallopian tube. It could be in the ovary as well, right? Then you could have miscarriage or abortion as the cause of acute pelvic pain as well. And if you look at the pregnancy, the causes of acute pelvic pain outside of pregnancy, well, again, it could arise from all of this area, and you could have maybe an ovarian cyst, right? Now, ovarian cysts will usually don't cause pain. They don't. They do so when, let's say, there is an ovarian torsion, right? When, let's say, the ovarian cyst ruptures, when, let's say, there is bleeding into the ovarian cyst, so there is hemorrhage from this ovarian cyst, I mean, then it can give rise to acute pelvic pain. You could have pain arising because of inflammation in this area, right? One important cause of pelvic pain could be endometriosis. So it could be the first presentation of endometriosis, right? It could be a pelvic inflammatory disease, acute PID. Right? There could be pus collection, blood collection inside the pelvis. That could be the reason. So it could be a tubo-ovarian abscess. Whatever be the underlying reason behind this is a separate topic in itself. But broadly, these could be the gynecological causes of acute pelvic pain. Now let us analyze further to see how do we go about eliminating these causes. For that, we need to answer some basic set of questions, like what is the character of pain? Knowing the character of the pain gives us an important insight or clue as to the possible cause. I mean, the onset of the pain, if you look at it, could be rapid. So it is sudden in onset, it rapidly progresses, a sharp stabbing kind of a pain, or there could be a severe, maybe colicky, cramping sort of a pain, which is progressive in nature. So yes, a character of pain will give us an insight. Let's talk about the rapid onset and sharp and stabbing pain. Now, rapid onset of pain usually happens with perforation of a hollow viscus or rupture of a hollow viscus. What could that be? That could be a tubal ectopic. So that could be a ruptured tubal ectopic, right? That could be an ovarian cyst which has possibly ruptured. So there could be a ruptured ovarian cyst. There could be an intestinal perforation or rupture. And there could also be another situation. If you see here, this is the ovary connected to the lateral pelvic wall by the infundibulopelvic ligament. The vascular supply, that's the ovarian artery, comes to the ovary by way of this infundibulopelvic ligament. And this ovary, especially in the presence of a huge ovarian cyst or a mass, could undergo torsion along its vascular pedicle. So when torsion will happen along its vascular pedicle, you see there's going to be ischemia and necrosis of this viscera. And yes, there can be ovarian torsion. There could be the entire adnexa, tubes and ovary, which have undergone torsion along its vascular pedicle. So that is another possibility for rapid onset pain, right? Rarely, yes, but possible. Rarely, yes, but possible. Sometimes you can have a pedunculated subserous fibroid that can also undergo torsion, and that is also a possibility. Will present with acute abdominal pain, acute pelvic pain, right? So that could also undergo torsion. Now, moving on further, let's talk about the other character pain, that is severe colicky or cramping nature pain, which is progressing. Now, severe colicky or cramping nature of pain usually arises when there is obstruction of hollow viscus or viscera, right? So what could that be? You could have intestinal obstruction, right? You could have stones, right? So ureter stones, you could have bladder stones, colicky pain, right? In the lower ureter will be referred towards the pelvic pain, or you could have crampy pain because of uterus, crampy pain from the uterus, right? Now that's because the contents that are in the uterus, let's say for example, as in the situation of miscarriage, the contents are being expelled out and the uterus is contracting to help the expulsion of those contents, leading to crampy pain arising from the uterus as well. Okay. Now, moving on further, once we've noted the character of the pain, the other important pointer would be the location of the pain. Now, understand here that the first onset of a visceral pain is usually vague, not localized, right? It is usually vague in nature, and the patient cannot localize it to a particular point. The autonomic reflex responses are present in those circumstances, right? But yes, give it some time, pain will start getting localized to a region on the anterior abdominal wall, and then that is called as the referred pain. Some very basics of how pain presents, that is referred pain, is referred to a portion on the anterior abdominal wall. Now, where should that location be? See, now when you have pain that is arising from the, ovaries or the lateral parts of the fallopian tubes, or from the upper ureter, the lateral parts of the tubes, the ovaries, the pain is localized to this T9, T10 area. Okay. And when you have pain arising, let's say from the upper ureter here, you have pain arising from the rest of the part of the fallopian tubes, rest of the ovary, the other parts of the uterus, they get localized to this T11 to L2 segments. Even from the upper ureter, it will go to the same segments. Pain from the lower part of the rectum, right? Pain from the lower part of the small intestine, right? Pain from the bladder, pain from the large intestine, right? It also goes to the same areas, that is T11 to L2 segment. So somewhere here. And yes, it can be localized to either side, depending upon which sided viscera is involved. And once the pain starts getting generalized, if you have generalized pain abdomen, that means it is in the pelvis, maybe, but the patient is not able to point a finger at it. That is how you ask the patient to localize the pain at a particular point. He is not able to put a finger at it, then it becomes generalized all over the lower abdomen or pelvic area. That means maybe there is pus, maybe there is fluid, maybe there is blood collection, right? So when blood starts collecting, or pus starts collecting, or fluid starts collecting in the pelvis, nearby structures and everything, patient starts complaining of generalized pain, because you see, any of these collections actually irritates the pelvic peritoneal lining, and that irritation of pelvic peritoneal lining causes generalized pelvic pain, can also cause peritonitis, peritoneal inflammation, and then leads to symptoms suggestive of peritonitis as well. So keep these important basic concepts in mind before we start our evaluation. Now, moving on further, let's talk about the evaluation of acute pelvic pain. So when we're going to evaluate a patient, you see, our evaluation is going to involve a thorough history taking. You see, we have to note the nature of pain, the character of pain, how did it start, when did it start, is it rapidly progressive, if there is any other kind of symptoms that she has. So you have to take a careful history to direct it towards eliminating the possible causes. Then of course, you will go ahead with your examination findings. And then of course, finally, you will take the help of investigations to help you come at the diagnosis. Now let us see, what do we ask in history apart from noting the character of the pain. So you have to take a detailed, careful history of pain, which I told you, character of pain, location of pain, the nature of the pain. Apart from that, you should also note the last menstrual period. Very, very important, extremely important in reproductive age group women, because it could be a potentially ectopic pregnancy or a miscarriage. So pregnancy associated complications are a very, very frequent cause of acute pelvic pain. In fact, the most common cause of acute pelvic pain in reproductive age group women. Do ask the last menstrual period. What do you want to know? You want to know if there is any history of a period of amenorrhea. Even if there isn't, make sure that you do rule out pregnancy by doing a simple urine pregnancy test, or maybe doing a simple serum beta HCG. So make sure that you rule out pregnancy at the offset itself. Moving on further, you also need to ask about any abnormal bleeding pattern. Yes, of course, because if there is a miscarriage that is happening, it will be associated with vaginal bleeding also, bleeding coming from the uterus, right? So you need to know about abnormal bleeding also, help you rule out the possibility of abortion, right? If there is any pelvic infection, maybe there is a history of discharge per vaginum, for any pelvic infection, for any acute PID. Past menstrual history becomes important. Maybe the woman now is presenting with an acute pelvic pain episode, but maybe there is some history which is pointing towards the possibility of endometriosis. Like there could have been a history of, dysmenorrhea or painful periods for a long duration of time. Or maybe there is a history of, let's say, painful coitus or painful intercourse along with it. Maybe there's a prior history of infertility also associated with it. So you're taking directed history to rule out the possible causes. Please keep that in mind. So past menstrual history or any such event in the past that might have happened, which is now it is very acute, but previously it was, yes, severe, for which she had to take some medical intervention or attention. It's very important to ask of these questions as well. So prior gynae disorders, maybe she's a known case of endometriosis, maybe she's a known case of ovarian cyst, maybe she knows that she has an ovarian cyst or an ovarian mass or an adnexal mass. So yes, take a history of these important points. History of sexually transmitted infections for the possibility of chlamydia and gonorrhea infections, which could be responsible for acute PID. So you should be noting these in your history as well. And yes, for the non-gynecological causes, maybe a prior medical or a surgical history will be helpful as well to help, think about the possibility of non-gynecological causes also. Now, moving on further, you do have to ask about the associated symptoms as well, which will point towards the organ of origin for the symptomatology or acute pelvic pain. So you could ask for gastrointestinal symptoms like, of course, there could be nausea, vomiting, maybe anorexia could be there, nausea, vomiting, anorexia. There could be diarrhea, you see, there could be constipation, right? Or there could also be blood in the stools, right? Maybe there is the absence of passing of flatus, absence of passage of flatus. So yes, if there is an absence of passage of flatus, gaseous distension, constipation, you start thinking in terms of intestinal obstruction. Diarrhea and nausea, vomiting. Nausea, vomiting you'll find in intestinal obstruction as well. But nausea, vomiting usually happens when the intestinal obstruction is way up higher. You can find diarrhea with gastroenteritis. And another important point that I want to point out here regarding the association of collection of pus in the pelvis with diarrhea. You see, please note that if there's a pelvic abscess, if there is a pelvic abscess, that abscess can irritate the rectum, that abscess can lead to a reflex autonomic response, and that can also lead to diarrhea. So keep that important information in mind. Urinary symptoms, if you ask me, yes, you should be asking for symptoms like urgency, you see, dysuria, painful burning micturition, frequency of micturition. You should be asking for hematuria, blood in the urine. You see, you should be asking of any other history. Let's say maybe she's a known case of renal stones. She knows that. So there are cases, you know, when patients know that they have kidney stones, and then, you know, as and when they're taking treatment for renal stones, then the stones are passing through the ureter, and then when they reach the lower ureter, they can have an acute pelvic pain because of that reason. So please keep that in mind. History of stones become important, right? So you have to take a note of associated symptomatology also. Carrying forward the associated symptoms, you should be looking for symptoms and signs of underlying infection. You should be looking for fever, right? And you should also be looking for maybe a raised WBC count, signs and symptoms suggestive of infection, right? You should be looking for signs and symptoms for hemoperitoneum, blood collection in the pelvis. I mean, if there is hemoperitoneum, that means, you see, blood is collecting in the pelvis, then obviously features of blood loss are going to be there. So features of blood loss are going to be there. It's when the hemoperitoneum occurs because of any perforation or rupture of any hollow viscus. You see, there's a very rapid flow of blood into the pelvic cavity, and depending upon the degree of blood loss, and there's no visible blood loss, mind you, so the patient might look very pale. The patient will also have maybe a fainting attack, syncope, you know, she'll complain of dizziness, right? She'll complain of diaphoresis and sweating, apprehension, you know, she could just be very anxious, and that is a very significant you know, finding, because many people miss it, this dizziness and diaphoresis and syncopal episode. So make sure that you look at it. She could be extremely pale because of losing a lot of amount of blood inside the pelvis. And as and when you see the most dependent part of the pelvis in a normally standing woman is the pouch of Douglas, like deep down. So yes, blood will start collecting from there, and as and when the amount of hemoperitoneum is going to drastically increase, you see, blood could collect in the right paracolic gutters as well. So that would be massive hemorrhage. So if there's massive hemorrhage and blood collects underneath the liver, you know, on the undersurface of the diaphragm in the right paracolic gutter, you see the phrenic nerve, that is your C3 to C5 segments. I mean, that could be irritated, and then yes, you can have pain here, shoulder pain, or you could have a right upper quadrant pain. So look out for right upper quadrant or shoulder pain. That would be suggestive of massive intraperitoneal hemorrhage, right? And yes, of course, signs and symptoms of underlying infection. I mean, if there's peritonitis, if there is generalized peritonitis or pelvic peritonitis, you may have fever or evidence of other findings like guarding tenderness and rigidity on abdominal examination. So you need to keep all of these important pointers in mind, because when you're examining the patient on the whole, you need to focus on what are the possible causes and how you go about eliminating them. So once you've taken the entire history, you go ahead with your examination findings. You can find that your vitals, you see. Now, vitals, you see, obviously pain also causes tachycardia. You're going to check the pulse rate, the BP, you're going to keep a check on the temperature. So yes, pain itself can cause tachycardia, but if there is tachycardia as well as low BP, you know, it's a sign of blood loss. If there's no visible blood loss, you know, make sure that there's no hemoperitoneum. You need to evaluate that possibility. Also, in cases of sepsis, severe sepsis, maybe peritonitis, because of severe sepsis, could also have, you know, low BP in that situation. So noting the vitals is very, very important. All right. So you can have low BP, tachycardia in cases of hemorrhage, hemoperitoneum, or also in cases of severe sepsis. Temperature will give you an idea, right? High temperature fever will point towards infection. Pallor, patient is visibly quite pale. and looking quite pale, and the vitals are disproportionate, and there's no visible blood loss, you think of hemoperitoneum. On per abdominal examination, if you find guarding, tenderness and rigidity, okay, alone or in combination, you think about the possibility of peritonitis. Think about the possibility of peritonitis, and this peritonitis happens because of irritation of the pelvic peritoneum. That can be blood, that can be pus, that can be fluid. All right. Now, the other important thing is if there's no guarding, tenderness and rigidity, there will be some obviously pelvic tenderness, rebound tenderness whenever there is acute pelvic pain. And yes, you can localize the tenderness to one particular point in the pelvis, maybe right side, maybe left side. That will help you analyze the important causes as well. So if there is a right-sided pelvic pain, maybe it's because of an adnexal involvement on one particular side. If there is a suprapubic pain, maybe it's because of bladder and UTI. So that's central pain. So keep these important points in mind as well. Now, next, if we suspect a gynecological cause, we will go ahead with the pelvic examination. It is important that we do a per speculum examination to look at the cervix, if the cervix is healthy, if there's any discharge coming from the cervix or not. In the per vaginal examination, we will note certain important points like the size of the uterus, right? Any adnexal tenderness, any uterine tenderness, right? Any adnexal mass, right? If there is a mild amount of fluid or blood or pus collection in the pelvis, you see if there is anything that is collected in the pelvis. So you have this diagram here. This is the rectum behind, and that's your peritoneal reflection posteriorly, and that's your blood. So even little amounts of blood that collect, in this pouch of Douglas. I'm showing you blood in the pouch of Douglas. It could be pus, it could be a fluid as well. It could irritate the peritoneal lining here, and then there could be cervical motion tenderness. You are digitally doing a PV when you're moving the cervix, right? The peritoneal covering over the posterior aspect of the pouch of Douglas here, posterior vagina in the upper part, that moves and that causes cervical motion tenderness. That could be there. And sometimes when we're doing a PV and we're trying to feel the fornices, we're not able to palpate for the adnexa at all or any adnexal part, simply because there's just bogginess. There's just bogginess in the fornices. So maybe there could be just plain simple bogginess in the fornices. That will also point maybe there's some collection in the pelvis, right? So based on these examination findings, you will think more in terms of a gynecological cause of pain, and do not forget to rule out pregnancy in the very beginning. That will be a very big help, because then you can quickly move towards the diagnosis of maybe an ectopic pregnancy as well. Now, moving on further, what are the investigations that you are going to use while evaluating a patient of acute pelvic pain? So if you talk about the investigations, you see, you need to set a baseline investigation. I mean, you need to send the complete blood count along with the differential leukocyte count. You need to see elevated WBCs and neutrophils in case of an acute infective process, right? You need to send for investigations like urine analysis. Urine analysis will help you in finding out if there is a urinary tract infection, right? And basically, you will also start with a pelvic ultrasound. I mean, that will help you rule out the possible causes. That will help you find an etiology. And also, you need to do a screening, especially if you're suspecting a gynae cause. You need to screen for chlamydia and gonorrhea. So these could be a baseline set of investigations. Now, the other investigations will be required depending upon the situation. Like for example, if there's acute pelvic pain with element of hemoperitoneum and shock, then of course you want to go for blood grouping, cross matching along with it. You need to send a sample for that. and you need to arrange the blood also at the same time. You also need to have a baseline, maybe kidney function tests, right, in a patient presenting with hemoperitoneum and shock. If there is sepsis, element of sepsis and peritonitis there, maybe you want to send a full renal profile along with liver function tests. And maybe if your diagnosis is not made by the end of a clinical examination, even after doing a pelvic ultrasound, you see, maybe then you can think of higher investigations of radiology like CT scan, but they will come secondary. So these are the baseline set of investigations which can help in most of the situations for you to arrive at a diagnosis. So you should know the important, the basics about how pain works, how the pain pathways work. And once you know that, please remember that knowing the character and nature of the pain and the location of the pain will help you eliminate a lot of possible causes. Careful history taking, directed questions, right? Again, to help you rule out the possible causes, right? Keep in mind that there can be serious life-threatening causes of acute pelvic pain, and that's why you need to watch out for the signs and symptoms of peritonitis as well as hemoperitoneum. So the point of the matter is that if you go for a step-by-step procedure, like you know that you need to rule out pregnancy complications, you know that you want to find out about the life-threatening hemoperitoneum if there is one. So you have to approach it with directed history taking, then you have to approach it with a step-by-step clinical examination so that you don't miss out on anything. At the end of it all, you need to send these baseline investigations. Make use of a pelvic ultrasound, that is very handy, that can help you come to a diagnosis. An ultrasound can show you an adnexal mass, an ultrasound can show you maybe evidence of appendicular lump, an ultrasound can show you blood or pus collection inside the pelvis, an ultrasound can show you a tubal ectopic, an ultrasound can diagnose an abortion for you. So a lot of the diagnosis can be made by a pelvic ultrasound, right? And other investigations will depend upon what is the nature of your patient. Now, in the upcoming video, I will be talking about the specific differential diagnosis of acute pelvic pain concerning the gynecological causes of pain and how do we differentiate among them.